And I'll just post this link to the group after.
Sounds good.
You would think. Sorry about that. Zoom pulled one on us. Okay, so here we are. And I'll just post this link to the group after. Okay. All right, so here we are back with another episode of Hernia Live with Medtronic, who I want to thank. I'm Brian Jacob, representing the International Hernia Collaboration. We have an amazing panel up tonight to talk about the introduction and actually in-depth world of radiology and hernias. And here is our host, is Dr. Salvatore Dosimo from Stony Brook School of Medicine. He's an associate professor of surgery, and we're really looking forward to what you have lined up for us, Dr. Dosimo. So take it away.
Thanks, Dr. Jacob. Appreciate it. And I just want to say, number one, thank you to Dr. Jacobs for hosting this for us. Thank you to Medtronic as well. And obviously, I think we have a fantastic panel tonight. It's my honor to really present them, and they're obviously going to do a tremendous job. But what we're looking at doing with this program is really just creating a foundation and an introduction to how to utilize radiology to diagnose hernias, number one, and then number two, to also plan your operative course. And then also down the line, as we kind of build on this foundation, we're going to start to see more complex hernias, more complex repairs, and also how to diagnose and deal with also complications. So I think we have, to start this off, we have a tremendous panel, and it's going to be my honor again to introduce them. And but our lineup, just briefly, is really going to be Dr. Ryan Yuza, Dr. Charlotte Horn, and then Dr. Pauli. And I'll give a little bit more of an introduction as we go along here. But no further ado, we're going to have Dr. Ryan Yuza, who's an assistant professor of surgery. And he's going to over at Chase, and he's going to Case, sorry, and he's going to be presenting dealing with normal abdominal wall anatomy and imaging. So Dr. Yuza, why don't you go ahead and kick this off for us?
Great. I'll take the controls here. A second. Good. Well, while that loads up, I'd like to say good evening as well. I'd like to thank the IHC and Medtronic for asking me to speak on this topic. As Dr. Dosimo said, I'm at University Hospital Cleveland Medical Center in Case. My practice is predominantly complex abdominal wall reconstruction. So I've been asked to talk about the topic of normal abdominal wall anatomy and imaging. And obviously we need to understand normal very well before we can understand abnormal. And so that's where we'll give a little foundation here and let the other speakers take it from there. Sal, we're not getting my presentation up here. Got that? Try, there we go. Okay, so that's me at the top. For the purpose of this, I have no disclosures to present. And again, in order to understand abnormal, we first have to understand normal abdominal wall anatomy. Oddly enough, as I was going through some of my slide decks and trying to put this talk together, it's very hard to find some normal abdominal wall anatomy when all the CT scans you get sent are of massive hernias. But we're able to find some and put this talk together. So I kind of broke the anatomy down into the different components of the abdominal wall, starting with the vascular anatomy. I'm going to use Dr. Rosen's atlas here for a lot of the pictures. It has some great detail. When we're thinking about the perfusion to the abdominal wall, the first vessels we think about are the deep epigastric system. Those jump off the internal thoracic artery superiorly, and also the external iliac artery inferiorly. These run behind the rectus abdominis muscles in the midline, and then coalesce at about the mid portion. So you get some sort of a watershed effect, but also collateralization. In the lateral half of the deep abdominal wall, you have the musculophrenic artery, which also comes off the internal thoracic artery superiorly. That runs just above the transversus abdominis muscle, and that collateralizes with the deep circumflex artery off the external iliac as well, shown over here. So that is our deep system. To demonstrate that in a CAT scan, this is a gentleman, like I said, I had to find somebody with a a good normal anatomy. And thankfully, this gentleman was sent to me with a small umbilical hernia, and the ED thankfully got a nice IV contrast enhanced CT. So we're able to use that for our purposes here. We're going to walk through here real quick. I'm going to jump to the, oop, there we go. Oop. Okay. Let's go back here and let's see if we can get this to play correctly. Okay. Maybe not. All right. So when we're looking at the external iliac arteries coming here in the inguinal canal or near the inguinal canal, we're looking at the deep epigastric system coming off here, and here. These are going to run from lateral to medial up under the belly of the rectus muscles bilaterally, here and here, okay? Those of you who do posterior component separations, you know about these vessels, all right? When you get down to the lower abdomen, you typically drop in the posterior rectus sheath and you raise this epigastric fat pad up so that it goes up with the rectus muscles anteriorly. You really want to preserve those vessels as you do your component separation. This was working easier before. There we go. As we move superiorly, these epigastric vessels begin to nest within the rectus abdominis muscle and continue in that path as we go superiorly. And then they are the deep superior vessels up top, actually right here and right here. And those go all the way up and join with the internal thoracic artery. The lateral vessels, the musculophrenic and the deep circumflex, are more difficult to see. They run in the intermuscular plane. And as far as this CT goes, I do not have good imaging of those, but you can understand that they run transversus, internal, external, oblique. They run in this plane out here. Jump to our next slide. The reason why that's important is because with abdominal wall reconstruction, we're usually going back in to fix incisional hernias, the most common cause for these large hernias. And oftentimes you're working after somebody's already done their damage, and that's through other surgical incisions. And these may ligate, transect those vessels. So if you've got somebody who's had a previous Coker incision or chevron incision, not only does it make your dissection of the posterior plane more difficult, but it's also highly likely that they transected those deep vessels, either ipsilateral in the terms in regards to a Coker incision, or sometimes bilateral with a chevron. Similarly, a low Fannin steel can take the deep system, McBurney. And other ones that we commonly see, or I commonly see, are if they've had a ostomy in place. Ostomy is obviously brought through the mid portion of the rectus abdominis muscle, and that can injure or ligate the epigastric vessel in doing so. You're working around that decreased perfusion in the area. And finally, I threw a cabbage on here. Somebody who's had their internal mammary harvested for cardiac bypass has had their deep superior system ligated, because that's obviously where the deep superior epigastric vessel is perfusing off, and the musculophrenic. So what does that look like in somebody? This is a patient of mine who had a Coker incision. So if we watch her deep inferior epigastric system here, all right, and as we progress superiorly, we still see it here. She's got a ventral incisional hernia, and then we get to their upper abdomen. Here's a area of her Coker incision. We know that by the denervation and atrophy of the muscle from the scar formation. And in here, what we don't see is the epigastric vessel, because it's obviously been transected in the repair. And what that can lead to is tissue ischemia later on if they've had most of their perfusing system ligated. jumping now to the neuroanatomy. You know what? There was a slide missed in there. I'm going to go back because I want to make sure we touch on it. There we go. It just jumped real quick. Here we go. Sorry, so that's the superficial system, which is also very important, particularly in cases if you're going to do an anterior component separation. These subcutaneous superficial systems can be ligated and lead to some of that tissue ischemia as well. The superficial system is perfused off the femoral artery to the superficial circumflex artery, which perfuses the superficial components of the medial and lateral abdominal wall. In the midline, there's a lot of perforators coming off the deep system to perfuse the central portion of the abdomen, including some periumbilical perforators. Had these slides gone in order, unfortunately, we skipped through them. That's another reason for some of that tissue necrosis that we saw on this slide. Somebody who's had their vascular system compromised at the abdominal wall.
Right, and that patient in particular, did they have any, was this a like an anterior component, or was this more posterior? Do you happen to know? Or an example of, I mean, we know that this obviously can happen, but do you recall the procedure for this patient in particular? No.
I don't recall this one in particular, no.
Yeah.
That's one of our slides, Ryan. That's a
Yeah.
anterior component separation done on somebody who had a paramedian incision.
There you go. I knew I lifted it off those slides, but I couldn't remember what they had back then.
So either way, it's your fault.
I believe that slide is courtesy of Dr. Luis Garcia from the University of Iowa.
There you go. So then jumping to the neuroanatomy, another important component when we're talking about abdominal wall reconstruction, we know that the neurovascular bundles that innervate the abdominal wall musculature come lateral to medial, running in the pre-transversus abdominis plane. Internal and transversus, they're running right between the muscles there. And then at about the level of the semilunar line, they pierce the posterior rectus sheath to innervate the rectus abdominis muscle. This is important because these nerves run in sort of a inferior oblique direction. So when these are injured, cut during surgery or trauma, you usually see some denervation and atrophy to the muscle bellies below the level of the injury. It's also important that they run above the level of the transversus abdominis muscle. When we perform a posterior component separation, we'll incise the medial border of the transversus muscle and try and lift these nerves up, send them up with our anterior abdominal wall as we run in the pre-transversus abdominis muscle, pre-transversalis plane, thereby preserving them. Here's a picture from a robotic repair. Here's the left rectus muscle, right rectus muscle. There's a linea alba. Here's a neurovascular bundle that we'll try and preserve as it inserts directly into the left rectus muscle here. And this is just an example of what happens when those are injured. Here's a denervation injury. We see the normal muscle bulk to the rectus muscle on the right side. On the left side, though, the rectus muscle is atrophied, minimal caliber. The fascia is obviously still intact and normal strength, but the muscle underlying it, the muscle belly, is significantly atrophied. Here are a couple of slides, patients of mine. This first one had a high left flank injury. Sorry, this is the lower spigelian. This is at the semilunar line. It's jumping around a lot. Okay, so an injury at the semilunar line. If we look at the muscle bulk at that level, all right, lateral is obviously preserved because the injury is medial to it. So lateral muscles are preserved. The rectus on the contralateral side is fine. The rectus at the level of the injury is relatively normal in caliber, and it continues that way all the way up. But down below, we start to see that the caliber of the rectus muscle is significantly less than on the contralateral side without the injury. All right. So this is the result of a denervation injury at that semilunar line.
Hey, Ryan, if I'm
Yeah.
not mistaken, that patient also had a, looks like a AAA repair, yeah?
Patient did, yep.
Right, and so I think this
That
is
may have been,
gives an opportunity to point out the fact that the lumbar vessels on that side, are also gone. And so as you think about this patient, not only do you have a denervation to worry about, but you actually have a devascularization of some of the lateral abdominal wall blood supply. So things to look at in addition to the where the area of denervation is.
I mean, not to skip ahead, but in this patient in particular, I mean, when you have that denervation, that it's obvious. I mean, when you're comparing to two different sides, plus like the decreased blood supply that we point out here, would you obviously stay away from anterior component separation or attempt sparing, or would you just go for posterior repair? I mean, that's obviously the importance of understanding what's going on radiographically.
Mhm. Yeah, absolutely. And in my position, I would still go with a posterior on this patient.
Yeah.
Try and reestablish. The patient doesn't have a midline defect, and you could consider approaching this in a minimally invasive fashion, getting your semilunar line back together and reestablishing the semilunar line all the way down. What you're not going to get is, once those nerves are cut, the rectus muscle is not going to come back. So it may benefit from a minimally invasive repair in that case. Next one here, this is a patient referred to me, had a history of some rib fractures, had a large upper left flank hernia at the costal margin, some denervation, and similarly, at the level above the defect, the rectus muscle appears normal in caliber. And then below the injury, we see the caliber of the rectus is very attenuated, atrophied compared to the contralateral side. And that continues down through the rest of the abdominal wall, more pronounced as we get more inferior. So those are the results of denervation injuries to the abdominal wall. And again, it's very important as you're doing, particularly a posterior component separation. Anterior, you don't run into these nerves as much, but a posterior components, you're looking right at them as you get to the lateral border of the rectus and making every effort to preserve those neurovascular bundles as you do your component separation, transition into the transversus abdominis, pre-transversus abdominis plane.
Ryan, another thing too is does this come with time in terms of understanding the denervation of like the rectus muscles, for instance? Is it just more seeing a lot of normal CAT scans, or are you just inherently comparing the two different sides and seeing if the volume of one is less than the other?
Usually it stands out pretty much to the naked eye when you're looking at that. But anytime I see a flank injury, rib fractures, a thoracoabdominal incision, a kidney, an open kidney, I'll look for denervation injury medial to that because they'll have transected all those nerves in doing their procedure. So have an eye for it. I don't look for it in somebody who's only had vertical midline incisions, but anybody who's been off midline, I'll be looking for some denervation injury. Yep. So then finally, myofascial anatomy, that's one of the more important, what we primarily focus on when we think about hernias. And this is where we spend the bulk of our time. Basic anatomy here, as we all know, the rectus muscles in the midline, vertically oriented fibers, have a posterior and an anterior fascia, which are composed of the lateral muscle belly or lateral muscle lamellas. The external oblique runs in an inferior direction, the internal oblique in a superior direction. They run at perpendicular angles to each other. And then the transversus abdominis muscle obviously runs transversely. In the cross section, we see the rectus muscle with the different investing fascia of the lateral muscles. The external oblique obviously contributes to the anterior component. We'll say this is at the mid portion of the abdominal wall, based on where the position of the three muscles are. The internal oblique contributes both an anterior and a posterior, and then the transversus abdominis contributes to the posterior layer. On this CAT scan, we got great real-time imaging of that rectus muscle, linea alba, and they've got 1, 2, 3 very easy to see lines attaching at the semilunar line on this patient here. A couple of variations of that, things that you have to consider, and this obviously becomes important to folks who do abdominal wall reconstruction and posterior components in particular, is that position of the transversus abdominis muscle, not as drawn in the previous slide, but better elucidated in this picture here, where we see that in the upper third of the abdomen that the transversus abdominis muscle inserts far more medially at the mid portion or posterior to the rectus muscle in the upper third of the abdomen, then begins to migrate laterally down towards the lower abdomen. That's a schematic drawing. Here's a CT scan that demonstrates exactly that. This is that very nice patient the ED sent me. He got great images because he was a thin, muscular guy with a small umbilical hernia. Rectus muscle transversus inserting almost exactly as depicted in that picture. And then migrating laterally as you get lower. Kidneys are here. We're in the mid portion of the abdomen. We're migrating towards the lateral abdominal wall. And then as we get down to the inferior third of the abdomen, and transversus muscle is all the way lateral away from the semilunar line.
That's a fantastic slide, by the way.
Yeah, well, I thank the ED for getting the images.
Well, I think it kind of talks to the point where I think when you're starting out, especially doing TARS, certainly, they always teach you to kind of, when you're doing top down, and start higher up where the muscles may be thicker, more medial. So I think that you kind of showing it there radiographically, you have almost a good landmark in terms of what to aim for in your preoperative planning.
Yeah, absolutely. And then once you get familiar to getting in these planes, it becomes much easier.
Yep.
The other point of distinction, and we all know about the arcuate line, favorite med student question we love to ask, and that again is that the transition of the internal oblique fibers that go anterior and posterior above the arcuate line, then migrate anteriorly along with transversus abdominis muscle, leaving just the peritoneum and fibers below. Here we see blown up images on the same guy, same CAT scan. We see those fibers going anterior, splitting, going anterior and posterior, and then going completely posterior, external, internal, transversus, versus in the lower half of the abdomen, here's the ASIS, the external, internal, and transversus, all migrating anteriorly to the anterior rectus fascia. We're saved by the peritoneum and space of Ritzius fat that allows us to dissect down below this level. Otherwise, we'd have a tough time reconstructing the posterior layer down low in the pelvis. So then just finally, sort of a top down, how I do it. When I get these folks, I get patients referred for a large hernia, how I read their CT scan. First thing I'll do is just kind of focus from medial to lateral. I'll look at the linea alba. Linea alba looks intact, 1 to 2 centimeters, no diastasis, okay? All looks good. He's got a little umbilical defect there, fat containing, right? Then I'll jump back up and I'll take a look at the rectus abdominis muscles. Are they normal caliber bilaterally? Are there any defects or atrophy? What is the width of the rectus abdominis muscles if I'm going to do a larger ventral hernia and I'm expecting to get enough coverage with just the rectus abdominis muscles or just doing a retrorectus repair? Is the retrorectus space wide enough to give me adequate overlap if I repair a larger midline defect? We'll look at that up and down. We can look at the vasculature like we talked about earlier, running behind them. And then I'll move out laterally, looking at the semilunar line and looking at the lateral muscles, looking for good, robust muscles, fat planes between them, and the integrity overall. And then finally, look at whatever specific pathology they're being sent to me for. We'll look at the defect size. That'll determine all that information, determine what repair I can offer them. We can look at other things that will complicate the case, i.e. previous incisions like we talked about, indwelling mesh that's going to complicate repair. And also you'll look for any other occult hernias, Spigelian hernias that are missed, fat-containing inguinal hernias, lipomas, as this gentleman has down low, because while I'm in there, I'll probably want to repair those at the same time. So that's normal abdominal wall anatomy and imaging. That's how I read it. I'll pass it on to the next group to to go into a little more depth. If you have any questions, feel free to reach out to me. My email's at the bottom there. And thank you again, Sal.
Ryan, that was fantastic. Really great. Quick question. Someone comes to your office, the majority of these patients, obviously they do come with CAT scans. So we have the ability to really sit down and like I said, look at what's going on anatomically and plan our surgery. But if they do show up, do you have an algorithm in terms of those individuals you will always get a CAT scan on and those who you won't? You kind of have an idea what's going on and you don't feel it's necessary, or does everyone get a CAT scan in your practice?
Yeah. Well, this gentleman, if he just showed up to my practice with that umbilical hernia, he would not get a CAT scan unless he had evidence of a midline incision around there. All right, that makes this an incisional hernia, and I want to know what the surrounding tissue looks like. Does he have some occult or Swiss cheese defects, either superior or inferior to that? Otherwise, basic umbilical, I wouldn't. If they do have incisions on their belly and they're coming for a lower midline hernia and they've got a laparotomy all the way up, I'll scan them. If they've got if they've got any other incision, I'll typically scan them so that I can alter my repair as necessary.
All right, fantastic, awesome, great. Thanks again.
Sorry, Sal. By the way, that's usually a non-contrast enhanced CT. They don't typically need IV contrast in my book. The non-contrast enhanced is typically sufficient, doesn't bag the kidneys, and will give me all the information I need.
Agreed. All right, awesome, great job. Thank you very, very much. All right, so moving on, next up is Dr. Charlotte Horn. She actually just finished her fellowship at the Cleveland Clinic, and she's going to shortly be joining the staff at Penn State, Hershey Medical Center, along with Dr. Paul. She's going to be doing a large amount of abdominal wall reconstruction as well there. So this evening, she's going to be talking about best imaging modalities and algorithms in terms of dealing with that workup of hernia. So Dr. Horn, take it away.
Thank you so much, and thank you for inviting me to be on the panel tonight. As Dr. Dosimo mentioned, I'll be talking about some of the imaging modalities for hernia repair. And a great segue to kind of what I'm going to talk about, as Dr. Juza mentioned, is how he kind of and who he kind of scans prior to seeing them in clinic. And I will say the only disclosure that I have is Medtronic, who's been so gracious to put on this event tonight. As I was finishing my fellowship, I always told Dr. Rosen, who is my fellowship director, that I was going to take members of his team. He had a great scrub nurse, he had a great circulator nurse, and I could take both of those and he didn't care. But the moment I said I was going to take his clinic nurse that arranged all the pre-clinic imaging, he lost it. So obviously this stuff is pretty important and can really improve the flow of your work and your clinic visits if you're very cognizant about who to image, what imaging to get, and it even can help kind of teach the patients about their hernia disease. So the objectives of my talk today are kind of talk about some of the indications for imaging, the best imaging modalities for different types of hernias, and then maybe if there's some situations as when not to image. So as Dr. Juza had mentioned, there's definitely a wide variety of hernias that we see in clinic, and some of them are pretty straightforward. An umbilical hernia on a skinny guy is probably easy to see and come up with an operative plan without any imaging. But most American patients may or may not be skinny enough for you to evaluate the extent of their hernia, or they could have a really complex abdominal issue, and you definitely need to kind of evaluate what's going on with some sort of imaging to decide the best repair for them. So I think that, in my opinion, imaging is to be used as an adjunct when you're kind of seeing a patient in clinic. It's important to not only get all the operative records, but get some sort of imaging, as well as ensure that you are doing a physical exam. Because as Dr. Juza mentioned, you need to look at the incisions, kind of know what sort of previous wounds that they've had, if they have any, and the CT scan or whatever imaging you choose to get can kind of help correlate the information in the operative notes, because sometimes the type of mesh, where the mesh was placed, is not clear in the operative note. And so by getting some sort of adjunct imaging, you can kind of help decipher what happened when they've had previous hernia repairs. So I think some of the benefits of getting imaging preoperatively is you can understand where the mesh is placed. I've read quite a few op notes that say we placed a nice piece of mesh in the abdomen, and you have no idea where that is. So by getting some preoperative imaging, in this case a CT scan, you can kind of see, was this an onlay, a retrorectus, something intraperitoneal? In this case, this patient has had a previous peristomal hernia repair with stratus. And so there's a retrorectus piece of mesh here compared to this patient who had an onlay on the left with a piece of mesh, as well as, in terms of where that mesh is related to how you want to fix this hernia. So on the right here, you can see that this mesh is kind of sitting right next to the hernia, and you'll have to kind of navigate around that or remove that in order to fix the hernia. I know Dr. Paul is going to touch on this a little bit more, so I'll just touch on it briefly. There is definitely different types of mesh that are visible and not. In general, EPTFE is dense. I will say I've also seen some biologic meshes that can undergo some heterotopic ossification. So if you do have operative notes that say that there is a biologic mesh place, but you see that something is very radiopaque, then be careful. You can also see if mesh is scalloped, which means you could have some dense adhesions to bowel below. Some of the poorly visible mesh, unfortunately, is the lightweight polypropylene. But I know that Dr. Paul is going to touch on this a little bit more, so I'll save that for him. Another benefit of imaging is operative planning. So one of the things that we've noticed is that patients that have a flank hernia, if you are about 8 centimeters away from the midline without midline defect, those hernias should be approached laterally. So imaging can really help tell you even how to position the patient in the OR. And not only do they help with patient positioning, but it can kind of tell you what sort of surgery is available to that patient. So if they have something that is amenable to robotic repair versus an open repair, as well as do you need to do a full TAR, or if they have a robust enough rectus muscles and a small enough defect to support a retrorectus repair. I think one of the limitations to imaging in this situation is if they have a pretty large scar or a significant soft tissue problem, that those are sometimes underpredicted on imaging. And so, really using imaging as an adjunct and not replacing your physical exam is important in these situations. So I think, as Dr. Juza mentioned, some of the indications for imaging are pretty much anything other than straightforward. If they've had any previous repairs, any sort of hernia repairs, and I think another thing is previous abdominal surgeries, then you can kind of understand what anastomoses are there, what is their anatomy that you're dealing with. And I think, if a patient, a lot of times patients have nausea, some vomiting, some abdominal pain, and it's kind of unclear if they're having truly obstructive symptoms. So if they've had previous abdominal surgeries and they're presenting with obstructive symptoms, you can tell if it's a hernia, or maybe there is actually a problem with an anastomosis that needs to be revised, and it might dictate the conduct of your operation. So I think in terms of deciding what imaging is best, you kind of have to just determine what's readily available to you, what's something that you can interpret well. And I think in general, the CT scan is the best way to do that. It's quick, it's readily available, it's easy to read, it's easy for patients to understand. And as Dr. Juza mentioned, I think that no contrast is the best for these situations for a couple of reasons. Number one, you're not ever sure of the patient's baseline kidney dysfunction. A lot of hospitals have policies about contrast because it can cause some nausea, and so they'll want patients to be NPO, which can be difficult. And then on top of that, oral contrast can take a long time for people to drink. So, if patients are coming from out of town and they want to have their CT scan done before a clinic visit, that can be difficult to coordinate. I do, however, think there are some indications for contrast. And I think that if you are dealing with a large soft tissue defect and you think that they need a flap, then it's best to investigate their vascular anatomy. I think if they've had a flap and you're doing a hernia repair after a deep or a tram flap, understanding the perforating vessels that are there, especially if they've had other incisions, kind of gives you an idea of, the carefulness that you need to be when performing these repairs so that you don't injure any of the vessels and have some soft tissue damage. I think another reason to include some contrast in your CT scan is if you're thinking of removing any inguinal plugs or patches. Those can often be very, very close to the iliac vessels or the epigastric vessels, and sort of, appropriately counseling the patient on the risks of the procedure, as well as being prepared for those operations and how to proceed. Contrast is definitely helpful in those situations. I think in terms of MRIs for hernias is really not the best use of an MRI. You know, they don't require any radiation and they're not user dependent, but they're not readily available. And I would say one of the really nice things about seeing patients in clinic is kind of walking them through their CT scan so they can understand, you know, their defect, how you're about to repair them. And I think that, you know, that's really easily done with a CT scan. It's kind of a little bit difficult to do that with an MRI due to the phases that are involved in that scan. So I think some of the limitations to imaging are really that it can underpredict some of the soft tissue involvement. As Dr. Juza mentioned, incisions matter, and unfortunately those might not be apparent if there isn't any sort of muscular denervation below. Sometimes it's hard to really evaluate the compliance of the abdominal wall muscles. So if you're dealing with a loss of domain situation and questioning whether or not this is going to be a bridge repair, you know, really being able to kind of feel how compliant those abdominal wall muscles are on exam is helpful. And I think that as, you know, people are kind of transitioning to virtual platforms, you know, this is really a great way to discuss their imaging with them over a virtual platform, but it is worthwhile to bring them into clinic and actually do a physical exam on them. So to understand any sort of wounds, drainage, any stuff like that, they might be missed on the CT scan. And I would also say that, you know, oftentimes radiology tends to miss things, or they're not, you know, abdominal wall reconstructive surgeons. And so making sure that you review everything yourself can really, you know, provide a little bit more insight than just the read does by itself.
Yeah, I think that's a perfect thing that you just mentioned there, is the fact that we are looking for very different things when we look at CAT scans, I think comparable to what radiologists look at. I mean, for the most part, they're going to read the hernia, what's in the hernia, and what's the size of the hernia. But like you mentioned, they're not going to look at, for the most part, you know, what's the denervation of the rectus muscle? They're not going to mention. And I think that's a key. And I think a lot of times, especially for younger, you know, for residents and juniors starting out, I think the key is to really look at the radiology that you've ordered, the CAT scans, read them, try to come up with your own read, and then look at the radiologist read and see if they're comparable. I think that's a good kind of habits to have early on. And another thing too, you even mentioned before that I want to touch upon too, is the fact that a lot of times these patients come with stories in terms of what was done to them before, and you know, they're not sure. And then you get these op reports and they're not clear at all. And then finally you do get your imaging and your radiology, and you get a totally different picture and a totally different story in terms of what was done, you know, previously. So I think that's obviously, you know, two major points that you certainly hit on.
If your review of the imaging study and the radiologist's review of the imaging study result in the same finding, you need to look at more and reread, yes, because you should definitely have a different read than what they do. I mean, almost 100% of the time, you're going to find different or more important stuff.
Yeah.
Well, and ultimately, I think you're the one that's doing the hernia repair. So having a good mental roadmap of what the epigastrics are like, how big their rectus muscles are, you know, any sort of potential difficulties, whether or not you're going there and their abdomen has had like multiple tackers unloaded in them, like that's something that's important and will kind of not only change how you're going to approach these things, but if you know you have gotten a CT scan and the mesh is completely scalloped and the bowel is placid there, you know, like I'm probably only going to do one of these a day because this is going to be a very complex operation, and I should probably counsel the patient that, you know, there's a risk of an enterotomy because this is a very dense adhesions. So I think absolutely, you know, as you're going through, it's important to read all the CT scans and kind of not only, you know, reread what the radiology said, but also evaluate, like, how do I want to approach this? What do I need to be worried about? How am I going to counsel my patient about the repair and the outcome of their operation? And so that's why it's very important to reread physically look at all the scans that you order.
Hey, Charlotte, I think that's great. One extra little point is the other benefit that we have is the ability to go back after a surgery and compare what we found versus what we see on the CT scan. That can give you little indications of even stuff that you might have missed, adhesions here or you know, mesh there, tacks here. So we have the ability to operate and then go back and compare what we found in the tissue with the imaging.
Absolutely. So I'm just going to switch gears a little bit to talk about inguinal imaging. And I know this might be a little bit of a controversial thing, as I think most people would agree that it is reasonable to proceed without imaging if you have a definitive physical exam that shows an inguinal hernia. However, in my fellowship, we had a pretty robust chronic groin pain practice, and it seems very frequently we had young athletic men that were coming into the clinic and they said, I had this pain, I got my hernia fixed, and now the pain is debilitating, I can't do anything. So I would just say, take a step back and caution if they're presenting with pain, like significant pain as a presenting symptom without any obstructive symptoms. And if their physical exam is relatively unremarkable, those people are someone that you should probably investigate other causes of their groin pain than a potential inguinal hernia. And we were pretty lucky where I did my fellowship. We had this wonderful MSK radiologist, which unfortunately not a lot of people have access to, but I really recommend, if possible, getting a dynamic ultrasound. And unfortunately, these are pretty user dependent, and we had a MSK radiologist that specialized in do them, but they allowed for a lot of pertinent information to be relayed to us. And that's because, you have the patient there, they take about an hour and a half, and the ultrasonographer is moving the patient, pressing on the areas of pain, and you actually get a good idea of the nerves involvement, the tendons, as well as if there's any kind of very, very small hernias. And I think that this is kind of the best thing to do if pain is the presenting symptom. I think, if you don't have access to a dynamic ultrasound or, a really good ultrasonographer, a pelvic MRI might be helpful because they can kind of help diagnose some of the tendonitis in that area. But I would say that if a patient presents with chronic groin pain or groin pain and not really much of a bulge, it's best to image those patients. CT scans are helpful. They can kind of tell you if there is a recurrence or if they have a hernia. I think in general, if you are doing a recurrent inguinal hernia, then, a CT scan might be worthwhile. In this case, as I had mentioned previously, they should be done with contrast just because the mesh tends to be closely related to some of the important vessels. And so you can get a really good idea of where that mesh is and then kind of decide the best way to approach it. Sometimes it's easier to approach these open versus a laparoscopic approach. So here's just a little algorithm of how to kind of approach patients. In general, I think if a patient has a ventral epigastric or incisional hernia, they should get a non-con CT scan. I think if they've had another abdominal operation after your last CT scan, it's worthwhile to get another one, and then kind of can proceed with your operative plan from there. Whereas if a patient has an inguinal hernia, if their chief complaint is a bulge, then it's reasonable to proceed to the OR without any imaging, except if they have a massive bulge and a potential loss of domain situation. But if they're presenting with pain, imaging is probably warranted in this case, and you should, if you can, get a dynamic ultrasound. If not, a pelvic MRI might be helpful to kind of really ascertain what is actually causing their pain. Thank you very much.
All right, Charlotte, that was fantastic. Great talk. Question, patient comes in and they have right groin pain, they've gotten a CAT scan, it was negative, ultrasound's negative, and you're concerned about a sports hernia. Do you go straight for an MRI?
I actually, before I would get an MRI, would have them do some rehab for a couple of weeks. If I think that it's probably a sports hernia, I think it would be worthwhile to get them to have some real physio. And if it gets better, then they probably don't need any imaging. I mean, if they're like questioned about the diagnosis, I think, one of the advantages of imaging, especially in these groin pain situations, is you can say that this isn't a hernia because you don't. And so a lot of times, if someone has a sports hernia or they've had chronic groin pain, they've probably bounced around from surgeon to surgeon. So sometimes you need to get imaging just to provide some answers for those patients. But in general, I think if it kind of seems like a sports hernia, I would refer them to physical therapy first. And then if things don't get better, then an MRI might be useful then.
Awesome. Great. All right. Thanks a lot. All right. So up next is Dr. Eric Pauli. He's a professor of surgery at Penn State. He's also division chief for minimally invasive and bariatric surgery. I had the pleasure of training with him during my fellowship. And I think it was probably the first day of fellowship, probably the first hour I was there. He called me to his office and he had a CAT scan up on his screen. He goes, "Hey, what do you see here?" And I said, "Oh, I see a big hernia." And his look of disappointment is what motivated me to really really kind of buckled down and learn how to read my own CAT scan. So Dr. Paul, as you were talking about understanding radiology and how to understand hernias. So take it away.
Thanks, Sal. I want to thank not only Sal for being our host tonight, but obviously Brian Jacob for running the event, and obviously Medtronic, our sponsors for the evening. It's been an awesome evening for me so far. You know, one of my former fellows is running it. One of my former fellows is giving a great lecture on anatomy. And then my new junior partner understands the importance of CT scans and can not only understand what's on them, but can articulate exactly why. And so I feel like I really lucked out here tonight. I'm going to try and put together some of the concepts that both Dr. Yuza and Dr. Horn were speaking about in terms of, you know, imaging modalities, normal anatomy, and then how we put those things together to really understand what the hernias look like. And as has been said multiple times, your ability as a hernia surgeon to look at these films and to understand what is on them, even when radiology has, I think, missed the mark to some degree, means that you as the surgeon are going to come away with a different set of information, which is going to influence and inform the operation that you offer the patient. If you go into the operating room with the best possible plan and you have technical skills, you will probably come out of the operating room with a very, very good result and obviously a very happy patient. And so for me, the hernia surgery starts in clinic with us looking at these scans to understand what's going on. I do have some disclosures, including the fact that Medtronic is sponsoring our talk for the night tonight. But we're not going to really talk about any specific products. If we mention specific mesh names, it's primarily because we're talking about how to find those specific things on imaging. I had the ability to visit my friend Philip Moisem's late last year, and we spent some time in Amsterdam, Conrad Balliser and Vedra Augenstein and Archana Ramaswamy and I, and we got to see some amazing some etchings. This is a Rembrandt painting, and I think the interesting part about this etching is that the title of it is actually called The Baby Walker. It's the stuff in the background, the real subtle stuff, right? The stuff that jumps out, the stuff that radiology says is there is important, but the important part of this is what's hidden in the background. And interestingly enough, Rembrandt painted this as a subtle reminder to your pupils that you can only master your craft, you know, through constant practice. And honestly, like, I couldn't have made this up. It's a black and white picture. It's explaining why you need to learn to look for stuff in the back. So let's talk about imaging and hernia repair. You know, you've heard us mention preoperative planning. I absolutely use it that way. You heard, I think Dr. Horn mentioned that during the operation itself, looking at the imaging for intraoperative assistance, what's going on in this area that I'm currently working in? Is there a hernia here? Is there bowel densely adherent at this location? How and where can I get around this area of difficulty that I'm working on? We're not going to talk about postoperative diagnosis and complication management, but obviously imaging, it plays a huge role in these things, as well as long-term follow-up and documentation of recurrences. Again, a lot of hernias are small and subclinical. When we start talking about posterior operations that involve sublay repairs, we know that many breakdown of the posterior sheath may not be palpable on physical examination. And so complications can be seen only radiographically. And as I believe Dr. Horn said, CT scans are probably the most useful overall, with the notation that MRI and ultrasound clearly have a role in specific instances. This is the important part. You know, imaging is in general standard and extremely common. The way we acquire the images is, you know, pretty standard from location to location. A patient can show up in my office with a disc from another hospital, and I can put it in my computer and I can look at it, and those images have been obtained in a pretty standard fashion. The big problem, as I understand it, is that interpretation of images of the abdominal wall and how reports are generated is completely non-standardized. And as a consequence of this, if you are lucky and work at a place like the Cleveland Clinic, where they have an MSK radiologist who will review those films, then you're going to get great dynamic ultrasound reports. And if you work at a place where they don't understand any of the stuff that you're looking for, you're going to get a report that says there's a hernia and maybe it describes some content and maybe there's some measurements, but maybe they're not right. We know that there is a greater than 70% discordance between how radiologists and how surgeons view these imaging studies. Ventral hernias are the second most common structure to be inaccurately reported on imaging, and ventral hernias are actually the most commonly missed finding. And I think this is an important thing that Ryan mentioned when he's scrolling through a scan, especially on a person who's had an incisional hernia. Yeah, there might be a hernia you can feel, and that might be reported on the CT scan, but are there smaller hernias up top, right? Am I actually doing a much bigger repair here than I think? I want to know that ahead of time, not when I'm in the operating room doing a preperitoneal dissection and wondering, have I actually gotten to the top of where this hernia is, or am I actually leaving hernias behind? And obviously, these inaccurate reports are an everyday occurrence. This is from the International Hernia Collaboration, right? The interpretation of this image was bilateral rectus diastasis with herniation of fat only. What are your thoughts on the CT scan? Well, here's my thoughts. There are some rectus muscles, and then here's a big old hernia with a bunch of small bowel in it, okay? And I don't know how you could really look at this and say that this is a diastasis. And so the comments, again, you need a new radiologist. Well, that's not really true, okay? The radiologists are busy looking for things that they need to read in the report or that are part of their standard reporting software. They're looking at livers and aortas and things that go bump in the night. And so the hernia is not their top priority. I think the second comment is probably a little more true to what I did when I first started, which is, if you call them and teach them the terminology, they can amend the report. And I still do that from time to time. If the interpretation of what they've said on the report is so off from what I'm seeing, I do talk with them and ask them if they will amend the report. If it's just that they didn't include all the information that I need to understand things correctly, I don't bother them with that sort of stuff. When I'm doing an anatomic evaluation, there are three things that have already been mentioned. It's the physical examination, it's getting abdominal imaging, and then it's getting the old operative notes. And it's really not until you have all three of these things, hopefully in the same room at the same time, that you can kind of put together an anatomic evaluation of a patient's abdominal wall. And this was mentioned, but the op notes are obviously important. What operation is the surgeon trying to describe? We know that op notes are not very good. This left paramedian juxta-umbilical ventral abdominal hernia incisional, this is an M3 incisional hernia, right? This could have been said in a lot fewer words. But as Dr. Horn said, knowing where the mesh was placed obviously is important as well. It's delightful when they say what kind of mesh was used. In our recent series on this, the most commonly used mesh was appropriately sized round mesh. I don't know who makes that. But knowing the anatomic plane is also helpful. And to be honest, many reports don't even describe the plane correctly. And you really can't tell whether it was above the fascia, below the fascia, preperitoneal. Very challenging sometimes. It's nice to know what planes have been violated before. Okay, did somebody try to do an external oblique release? Was it actually an external oblique, or did they just make a skin flap? And these are all things that you can try to match up with what's on the CT scan. I also like to know if adhesiolysis was hard from the old op notes, and if they had any enterotomies or colotomies, especially if they did them as hand sewn, because you're not going to see those staples on the CT scan. So obviously, physical examination is still a major part of examining a hernia patient, but imaging obviously is used to augment that, and it can't replace the physical exam. Physical exam alone misses 20 to 30% of ventral hernias because they're too small, or because there may be a dense scar overlying them or other findings. The patient that I took care of today in the operating room had a 14 centimeter wide hernia. As soon as she went to sleep, you could not feel the edges of the fascia. Couldn't feel them at all. It was actually shocking. We made the medical student feel, and he's like, I don't think there's a hernia here. And I was like, wait for it. It'll be there. There are clearly those things that you will see on imaging that you're never going to see on a physical examination, but obviously some things on exam that you're never going to find on a CT scan. So this is a patient who came to me with a obvious mesh complication. You can see in the actual patient image there that there are some areas where we have some drainage from the abdominal wall. And if you look at how subtle this is on the CT scan, I'm pointing out the area where there is eroded mesh coming through the skin and inflammation. Radiology is never going to be able to report that unless the mesh is something that's very dense like EPTFE. But again, you can look at this patient and see that there's pus here. You can feel mesh when you examine them. You can see mesh fibrils eroding out. Can't see that on the CT scan. I also like to know, how big is the defect? How wide are the rectus muscles? You know, here we see a patient with a nice midline defect, and we've got rectus muscles that are about twice as wide as the defect is. This person might be repairable with the retrorectus repair alone. Are there defects that are abutting bony landmarks like the subxiphoid defect? So we know we have to do a little bit of dissection above the bony prominences. Are the defects all in the midline, or are there some that abut the lateral abdominal wall, like this old ostomy site defect in conjunction with a midline defect? If we're going to do this repair, we know that this image, this defect right here is not going to have a lot of lateral overlap if we're trying to do a retrorectus repair. And so perhaps for this patient, an onlay where we can dissect lateral, or a retrorectus plus a TAR, or just a preperitoneal repair, right? Some operations are going to be better for this patient than others to fully cover that with mesh. I briefly mentioned, you know, this is the Carbonell ratio, as we affectionately call it. I don't believe that Dr. Carbonell has published this yet, but his resident presented it in 2019 at a hernia meeting. If you look at the rectus muscles and kind of add their distance together, and you look at the width of the hernia, if the rectus muscles are twice or greater the size of the hernia, then oftentimes these can be repaired as a retrorectus repair alone, without the need for any additional separation of components to get the midline back together. I think the caveat to this is, obviously you want a rectus muscle that's greater than 4 centimeters at a minimum to have enough overlap. If you've got 3 centimeter rectus, that's probably not gonna cut it, no matter what the ratio says. Mentioned earlier, you want to make sure that all the defects are being accounted for. Okay, here's a patient who came to me with a low midline defect from a fan and steel incision. And if you look, you can actually see here are the rectus muscles, and you can see content herniating in between them. But there's this other thing over here, and on these lower cuts, it's a little subtle. But if you go a little bit higher up, it's not so subtle, but it's also not in the report, okay? This is the lateral extent of a fan and steel incision. This is a partial thickness defect. It's a Spigelian type defect. External oblique is intact. Internal and transversus are disrupted. The problem is, if you miss this lateral hernia and you don't fix it, this person's gonna come back and say, hey doc, the stuff in the middle, great. What's this bulge on the side, and when are we gonna fix that, okay? And this obviously changes how much dissection you have to do and where you have to do it, because this abuts the ASI, as you can see. Dr. Yuza talked about denervation, and obviously understanding denervation is important, not only to know areas where you're not going to see normal muscle, but also areas where there's going to be intersecting scars that divided those nerves. And I think importantly, a discussion with the patient about the fact that they may have some areas that continue to bulge post-op, even after you repair them with mesh and cover their defects. This patient, for example, has a myopathy. This guy came to my clinic in a wheelchair for no obvious reason. He had no known diagnosis. We got this CAT scan for his peristomal hernia, and I looked at it and I'm like, he's translucent. I mean, there's literally no muscle here. He's got some psoas muscles, and that's about it. And we sent him to neurology, and they were like, yeah, he's got a severe denervation of basically everything, and a myopathy. And he actually had a very limited life expectancy as a consequence of this brand new diagnosis. And so we wound up not fixing his hernia. Finally, we're going to spend some time talking about mesh. You know, understanding where mesh is located and the planes that were violated and what is adjacent to the mesh, to me, is a very big determinant factor in what operation I'm going to offer the patient to do their recurrent hernia surgery. Okay, here's a piece of mesh from a previous failed repair. You can see a hernia here in the midline. As you scroll through the scan, one of the things that you'll notice is that you have bowel on both sides of the mesh. And I know from the operative report that this is a mesh that only has an anti-adhesive coating on one side. And so when I see bowel on the wrong side of the mesh, I get a little worried that it got there kind of early after the repair, and I might have mesh and bowel densely adherent to one another. And sure enough, when you go to the operating room, this may not project very well on the smaller screen here. We have bowel adherent to the uncoated side of the mesh, and we have bowel on the coated side of the mesh as well. And interestingly enough, when you take this mesh out, Darned if that doesn't look exactly like it looked like on the CT scan. This is that scalloping of the mesh that Dr. Horn mentioned earlier. Identifying mesh on CT scan becomes, I think, an entirely separate part of the evaluation. The ability to find it on CT is dependent on what surrounds the mesh. And so if there's fat around the mesh, it becomes easy to see even light and ultra lightweight meshes, okay? But there's got to be fat around it. Learning how to look for non-anatomic folds and wrinkles becomes a key. And then if radiopaque fixation has been used, that can easily show you the boundaries. But you as the surgeon have the advantage. You can read the operative note, and by reading the operative note, you're going to know roughly where the mesh was located, right? What plane, upper abdomen, lower abdomen, and then you can then look at the scan, obviously, with a bit of a jaundiced eye, right? You own a retrospectoscope in that regard, and you can tell what's already happened to the abdominal wall. And the radiologists do not generally have that information. Dr. Horn showed this slide earlier from a paper that Dr. Yuza wrote for the SAGES Manual of Hernia Repair. You know, obviously there are a wide array of meshes that could be added to this. Just realize that the thinner the mesh, the less the material, the less the coating, the less likely you are to see it. So ultra lightweight meshes and lighter weight meshes become poorly visible. Some earlier versions of this slide that we adapted this from say invisible, and that's not true, okay? They can be very hard to see, but they're not invisible, and you can learn how to find them. So how do we find them? Let's take a look here. This is a patient who had a laparoscopic repair, okay? And so what we can see from this is a non-anatomic wrinkle in the upper abdomen, okay? I can also tell you there really shouldn't be anything here. This is not the peritoneum, okay? You have fat above it that was not stripped off of the rectus abdominis muscle. This was just put against the falciform ligament. And you've got some omental fat below it. And lo and behold, suddenly what is missed by radiology or maybe thought just to be the peritoneum is actually a piece of laparoscopically placed mesh. Here's a patient who has a piece of mesh in the pre-peritoneal space. You may also notice that this patient has a denervation of the left rectus muscle. The mesh is a little challenging to see. And again, you guys are probably looking at this at a very small screen, so I apologize. But what I'm looking at is some pre-peritoneal fat on one side and some pericolonic fat on the other to know that that's where the mesh is. And obviously, I can also tell you that in the placement of this mesh, some of those nerves around the semilunar line were probably injured because we've got a denervation here that was not there on the imaging before this was repaired. Here's a piece of mesh that contains some EPTFE. This is the easiest stuff to see because it is very bright white on non-contrast CT imaging. We can also see some radiopaque fixation. We can see a recurrent hernia in the midline. And if I asked you to tell me why did this recur, you would tell me because they cheated the mesh to one side, right? They've got great overlap with the right rectus muscle and really no overlap with the left rectus muscle. And if I asked you to tell me what side of the patient the surgeon was standing on when they put this mesh in, you would tell me they were standing on the left. And sure enough, that's where all the laparoscopic ports are, okay? So again, you can start to understand not only find the failure, but start to understand and predict the mechanisms of failure as well. Here's an onlay piece of mesh. Again, this onlay was done without stripping all of the fat down to the level of the fascia. And so this mesh is actually sitting on a layer of fat. You can see fat above it. The mesh was secured to the fascia with skin staples, and you can see those skin staples there as the boundaries of radiopaque fixation. Here is a piece of pre-peritoneal mesh from an inguinal hernia. Again, the mesh has a little bit of a scallop shape, and you can see some fat on both sides of the mesh. You can, interestingly enough, see some tacks there as well. Those tacks are in the triangle of pain. The operative note actually says we were even able to place tacks in the triangle of pain successfully. And oddly enough, this patient successfully came to my clinic with pretty severe pain. So you can actually predict not only from where these tacks are, but from the op note, why this guy is having debilitating inguinal pain after a repair. Here's a well-placed piece of mesh after a laparoscopic repair. You can see it's very flat against the muscles. The way to find this one is to know the patient had a repair on one side. And then as Ryan was doing earlier, looking at anatomy to find denervation, if you compare right side and left side, you can see that there's clearly something thick behind the left rectus muscle here that is not present on the contralateral side. We can also see well-placed tacks that are above the iliopubic tract in this patient, and this person does not have pain. I can also tell you by looking higher up that this was a TAPP repair, because there are 4 tacks that were used to close the preperitoneal flap that was created. So again, without really examining the patient or reading the op note, we can figure some of this stuff out. Here is some retromuscular mesh that is actually fractured in the middle. Now this mesh, the mesh itself is actually challenging to see, but in the op note, as they did the retromuscular dissection, they used a lot of clips. And so you're seeing a lot of clips behind the rectus muscle here, and that's the clue that fills you in that there's mesh here. This mesh was surgically divided down the middle. So even though it looks like a central mesh failure, it's not. This was surgically divided and then sewn back together with some absorbable suture. Another piece of mesh on the abdominal wall, similar to that first piece that I showed you. Again, this non-anatomic fold and wrinkle that really shouldn't be here. This is a report that was read as a diastasis of the midline. This is a patient of mine who had a bridged repair as a temporizing hernia surgery with a piece of bioabsorbable mesh. And so radiology read this as no hernia, and I looked at it and said, yep, big hernia with a piece of mesh that's eventually going to go away. And so this was our pre-op scan prior to doing this patient's definitive repair. Now this is where it gets really challenging to find mesh, okay? This is retromuscular mesh. This is a retrorectus operation. If you look at this, you cannot see the mesh, okay? There's really no way to tell there's mesh here because it is isodense to the 2 things that are around it. But if you look, you can actually tell that this patient had a retrorectus repair with complete defect closure because there is essentially only one rectus muscle, all right? A well-done retromuscular repair, a well-done hernia surgery that brings those rectus muscles back together in the midline gives you this kind of one motor unit, one big rectus in the midline. And so this is the tip off that there is a repair here. Similarly, this patient had a transversus abdominis release. The same thing, this mesh is very flat against the rectus muscles, but what you can see in the middle is there's no linea alba. There's really just one big motor unit here, okay? Both of those patients that I showed you had mesh that was secured with transfascial suture fixation, which I did for the first several years in my practice. And then I kind of started to get away from it. And now what I primarily use is adhesive-based fixation. The only difference that I can tell on the scan when I look at them is that the mesh has some very subtle retromuscular wrinkles. Here's the mesh here, and these little sawtooth waves right here are retromuscular mesh, most noticeable in the midline where there's maybe a little bit of fat here in the preperitoneal space. Same thing, this patient is a retromuscular mesh. If you look very subtly, there are some small sawtooth waves right here and a little scalloped edge right here that suggests that this person was a retrorectus repair. And I can tell this was a non-transfascial suture-based fixation. There are obviously visible meshes that are available outside the US. This is a mesh that has some metal woven into it. You can see on MRI, obviously, that this mesh becomes extremely easy to identify in terms of where it's located. This is a picture from a textbook that Dr. Dosimo and Jeff Blatnick and I are currently editing. That'll hopefully be out next year from Springer. This is a chapter from Philip Moisems and one of his PhD colleagues who has expertise in 3-dimensional reconstructions of the abdominal wall. So look for that. I will mention finally that obviously sometimes things get missed, okay? This is a patient who I had booked and was performing a robotic TAR on, and I had done the full dissection. I'd closed the posterior layer. I was closing the anterior fascia, and for the life of me, I just could not get sutures to come through the abdominal wall. The needle just kept rotating. And I could feel I was hitting something. And so I stopped and I opened. And what I found was this old piece of whatever this is. I'm not sure if it was old biologic mesh or just a big abscess around some permanent synthetic suture there. And this grew out MRSA. So, and I missed it. And if you go back on the scan, it's there, but it's a small little fluid collection that looks like the loops of bowel that are up in the hernia. And everybody missed it. Radiology missed it. I missed it. And we're kind of already committed to doing a reconstruction at that point. A few final questions that you can ask. If the patient had a history of obstruction, as Dr. Horn said, you want to be able to look and find out, is that obstruction related to the hernia? Or is it adhesive related? And am I going to wind up doing a lot more adhesiolysis? Are there going to be dense adhesions and where? This is a patient who had a cystectomy, a radical cystectomy for bladder cancer. And I think the thing to note is that there is no longer a plane between the rectus abdominis muscles here and this loop of bowel. You've got to be able to look at this and realize that these things are one unit, and they're going to be pretty stuck together. Okay. Here's another patient. Here is a right-sided rectus abdominis muscle here. And this thing right here that has no plane of separation between the rectus, that's another loop of bowel that actually heads down to the ostomy that's in the patient's left abdominal wall. And if you look a little closer, not only is there this loop here, but there's this loop right here with no plane. You know what this is, Dr. Dosimo? This is the duodenum. And then this thing right here is the gallbladder. And so if you're not paying attention and you start coming through this, you're going to take out a loop of bowel that goes directly down to the stoma, and you're going to have to throw that in the bucket. You're going to make a hole in the duodenum, and you're going to wind up doing a cholecystectomy all in one go around. And we looked at this and we said, that area is going to be slow dissection. And sure enough, when you get up there, that's his duodenum, and the gallbladder is right behind it, plastered, just absolutely plastered. So there are times to go fast and there are times to go slow. And when you see this, it's an indication that it's time to go slow. Finally, you want to be able to figure out if you can close the fascia. Last couple of words on radiomics. And I'm not sure if we're going to talk about this, Sal, in later lectures. Radiomics is the use of imaging studies to find details that you really can't find by any other method. And so these include things like looking at subcutaneous fat, looking at fat distribution in the intraperitoneal space, looking at the density of the liver to determine whether there are problems that might alter your strategy. So if you look at imaging and determine that a patient has NASH on imaging, it actually predicts postoperative hyperglycemia in hernia patients. Surgical site occurrences are associated with this finding. If you look at fat distribution, adiposity can predict adverse outcomes. If you are a type 2 diabetic and have two CT scan markers of obesity before your hernia surgery, you have a very statistically significant, high statistical chance of having surgical site occurrences, many of which involve a procedural intervention. You're in fact 11.5 times more likely to develop an SSO than if not. And again, this now informs your discussion with the patient preoperatively. You can also predict emergency hernia surgery from these. If you look at this OER score, the odds ratio of emergency surgery, you need some stuff clinically, like what's the patient's BMI, and you have to look at the CT scan for ascites. Then you're going to measure the angle that the hernia sac comes off in relation to the anterior fascia. And you're going to measure the angle. You get 2 points if the angle is 30 to 70. You get 5 points if the angle is less than 30. And they're going to measure the sac height. So I'll measure the sac height from where the fascia should be. And you put these things together, and it's actually predictive of the need for an emergency operation. If you have a score that's greater than 10, you have a 2.5 odds ratio of needing an emergency operation. So this can actually help you prioritize patients in terms of where they should be in line for their operation.
Are you using that?
I have not used that yet. No, I mean, I just kind of put people in stack where they come. I think there are some other things that probably could be added to that score. I mean, that's a for the most part imaging only score. I mean, obviously, if someone comes to you and they're having crescendo bowel obstructions, right? I mean, that person, none of that is in the score, and obviously that's important stuff. So I'm going to conclude here with 2 more Rembrandt drawings. Same content, same artist, just done years over the course of time. This is Beggars Outside the Temple. Again, I think as you start to look at these things, you should be able to fill in a lot of the details and see the things that are being missed by radiology, and then obviously become a much better hernia surgeon. And I really do applaud Sal for putting the series together. And obviously we thank our sponsors, Medtronic, for understanding that this stuff makes hernia surgeons better, and for sponsoring an event that lets us talk about things that are really not specifically related to their product, but that do make all of us much better hernia surgeons. With that, I'll conclude. Thank you.
That was a fantastic talk. And I think, anybody watching that, if they don't understand or start to appreciate the importance of really understanding how to one, how to read radiology, and 2, how to use it to alter or to, plan your surgical procedure. I mean, I don't know what else would kind of change your mind, but that was really fantastic. Couple questions. First, in terms of Hounsfield units, which you kind of mentioned at some point, is it useful, or has anybody looked at that in terms of using it to determine what type of mesh is there and if mesh is there, or is it just not enough radiographic information to calculate that?
That's a great question, Sal. So obviously understanding windowing and understanding Hounsfield units is kind of like a little bit of next level imaging processing stuff. I don't know if anybody has actually used the Hounsfield units of mesh as a predictive of whether it's light, medium, or heavyweight, but that's an amazing research project that could easily be done because these images, already exist and you probably already know what mesh is in the patient. So be kind of fun to do.
All right. Well, I guess we just started a race to get that done.
I got 3 lab residents just clamoring for stuff, man. Get ready.
Exactly. Just put me on. Thanks.
And I've got a junior partner who's eager and interested.
Perfect. Perfect. So the radiomics that you mentioned too is interesting because, years ago, now years ago, but back when I was a resident, when that first started coming out, we did some studies on that. We found that, looking at, visceral fat adiposity, even back then we were looking at some of the information in terms of diverticulitis, and we found that patients with higher levels of, visceral adiposity on CAT scans had more higher chance of having diverticulitis and worse outcomes. And there is some component to the fat in terms of inflammatory markers and how it really can alter your outcomes. So the fact that, it's nice that you mentioned that, because it definitely is, I think it's definitely another level to the radiology in terms of how much more can we use this to really predict our outcomes in our preoperative planning. So it's nice to mention that.
Yeah, if I recall, you brought that concept to us, and I think you and I first looked at a study on visceral adiposity and surgical site infections, and we didn't really find a correlation, but we had a really low surgical site occurrence rate, mostly because we had worked out a lot of the things. We were reducing fat, we were stopping smoking, we were controlling diabetes down to A1Cs of 7. And so we weren't able to find infections. But I think if we had gone back and redone that study and looked at surgical site occurrences and seroma formation and other things, we probably would have had, some positive results, just not the infectious stuff that we're interested in.
Great. Awesome. Well, listen, I think we're kind of getting toward the end of the time here, but I just want to say, I hopefully people out there watching, you've enjoyed this. I loved it. I learned some stuff, obviously, which I'm sure everyone else will too. And I think this is going to be the first of, plan is to be first of a few more down the line. We're probably going to have about 4 or 5 more sessions of this. And obviously, as we go on in time, we're going to make it, the complexity is going to increase. And hopefully this sets the foundation to build on this. And, for the speakers, thank you so much for your time. Much appreciated. Again, thanks, Brian Jacob, for hosting us. Thanks to Medtronic for supporting us as well. And Dr. Hughes, Dr. Horn, Dr. Pauli, fantastic talks.
Sal, what are you planning on doing for the upcoming lectures, just so that people who are watching know what to look forward to?
Yeah, we're going to plan. So we're going to have different sections. We're going to start, probably next one's going to be ventral hernias. At another point, inguinal hernias, atypical hernias. And then really we're going to look at something, we have kind of broad topics in terms of radiology and hernia repair follow-up parts 1 and 2. And that's really going to be more of the, post-operative complications, the complex hernias as well. And so we'll kind of fill those in as we go. But the next one up is going to be ventral hernia for sure, then inguinal hernias. And we're probably going to do about one of these lectures per month in the next few months. So, kind of buckle up and just kind of look forward to it. And as we go along, we'll give you a good heads up in terms of when the next lectures are.
And I think if you're on the IHC and you're watching this, please feel free to drop some comments. If there's a particular topic that you think would be beneficial, or a question that you have that will relate to one of the talks we're going to do, please, let us know, and we'll try and work it in.
Absolutely. Yeah. Anything, any comments and, or anything that we can make this better and useful for everyone out there too, let us know. Appreciate the comments. All right. I think with that, I'm going to hand it off to Brian for any last comments.
Appreciate that. You guys, great job. Certainly kept me engaged the whole time. There's no additional comments other than to say that I really think that radiology and hernias is significantly undertaught in many disciplines, and this should almost be mandatory for residents to start learning. When patients come into the ER, the residents are the first people down there. And I think radiology residents and surgery residents alike would really benefit from this education. You all are clearly masters at this, and I appreciate learning from you and look forward to continuing that. And thank you for choosing the IHC to host it. And again, thank
Appreciate
you
it.
to Medtronic.
Thanks again, everyone. Have a fantastic night.
Bye, everyone.
Yeah.
Thanks, everyone.
Thanks.
Thank you.